Thanks. All right, well, let's talk about Utah. We first noticed in our state data that non-suicide poisoning deaths had surpassed motor vehicle crash death for our data for 2003. And sadly, that has continued and the gap is widening. A lot of the national data that we see come from vital statistics. And what I'm going to talk about today is a lot about data and how we know some of these famous figures that you see. So I'm going to start with vital statistics. Okay, so this is national data. And one of the challenges with vital statistics data is the time lag that's associated with these data. And this is a common challenge when we're trying to use administrative data sources for surveillance of public health events. By the time those death certificates are recorded and coded and back and available for analysis, a lot of time has passed. And by the time we can use this really high quality data, I mean, it's clean, to study a problem, the problem may be completely out of hand, or it might have dissipated entirely. And for the case of drug poisoning and drug overdose, I think it was much more on the out of hand side before we could really use drug death certificates to do that. And for any decedent to have a drug-related code show up on a death certificate, the certifying official must have included a drug-related immediate or underlying cause of death. And I know this seems really obvious. You're like, why are you saying that? But take a look at this next slide. And whoa, did I lose a slide? Oh, no, I just didn't click far enough ahead. So these are some of the codes that can show up on death certificates. And it comes to both the type of drug and the manner of drug. And so we heard earlier about suicide, which are X60 codes. And these are for accidental poisoning codes, which are the X40, 42s, so on. These wouldn't be there if your doctor or whoever certified didn't think that this was the problem. Okay, now consider age. The biggest increase we've seen in death rates as measured by death certificate data has been reported for persons aged 55 to 64, which is the light green line there. But note that the rate we have seen has barely changed for persons who are age 65 and older, all the way at the bottom. Now, we know that elderly individuals take a lot of opioid medications, but we see very few deaths among that group attributed to opioid medications. And I suspect this is a case of competing causes of death. In a patient who's taking opioids for advanced cancer, the opioid may well have hastened the death, but the death will likely be certified as due to cancer rather than drug poisoning. There's not likely to be an autopsy or medical examiner investigation in a situation where the decedent was in poor health or the death was not unexpected. So I think that even with the staggering number of opioid-related deaths that we recognize, we're still underestimating the impact among people aged 65 and older. So for some deaths, specific drugs are noted on a death certificate using T codes. For example, many of the drugs that interest us, hydrocodone, oxycodone, would be included along with morphine in T40.2. Methadone gets its own code, T40.3. And in order for a drug to be included on a death certificate, the certifying official must be of the opinion that the drug was an underlying cause of death. Hence, if there was no suspicion of drugs or no toxicology testing, then specific drug information cannot be gleaned from a death certificate. For a recent data year in 2011, the report notes that 25% of deaths certified as drug poisonings did not actually include any specific drugs. So these may have included a code T50.9 for unspecified drug-related cause, but this is just illustrating another limitation of using death certificate data for surveillance. So keep this in mind. Next figure. The type of opioid medication may also have something to do with rates or risks of adverse events. Vertical axis here is just counts of death, not rates. But what I want you to note is that most deaths are attributed to the natural and semi-synthetic drug category, which includes the most often prescribed drugs, hydrocodone, oxycodone, morphine. Methadone is a synthetic opioid, and it alone is responsible for more deaths than the rest of the synthetic opioids, such as fentanyl, meperidine, and propoxyphene combined. But the deaths reported here are limited to those which actually include a specific T code, so it's not all the deaths. In Utah, we can use our local medical examiner data to describe involvement of opioid medications more specifically. Note here that the categories are not mutually exclusive, so you can't sum vertically to get annual numbers of deaths. But many poisonings are due to multiple drugs, and these drugs would be represented in ICD-10 coding with at most 3 lines. So we can get more specific data at a state level, but without additional data about prescribing, we still can't estimate risk to patients taking the drugs, and we can't compare easily to other places. So back to the US, death certificates. Again, this figure is numbers, not rates, but please notice there's an increase in reported proportion of deaths for which benzo drug is reported to be involved with the opioid, reaching 31% of the opioid deaths in 2011, up from 13% in 1999. You have to wonder how much of this increase is attributable to increasing awareness of mixed drug poisoning as a cause of death, and thus inclusion among the underlying causes of death compared to earlier years. Death certificate data can't answer that question. We need to include prescribing data and determine if deaths were occurring out of proportion with prescribing over time. So I'll come back to some of the national data, but I want to show you some of the things that we've been able to do in Utah. Our story begins in 2004, where our medical examiner noticed more deaths caused by prescribable drugs and asked epidemiologists at the Utah Department of Health to take a look at the data. And so we did. And we're lucky we have centralized statewide medical examiner data, so we could do this. And I reviewed all the drug poisoning deaths that we had between 1991 and 2003 and categorized them by the type of drugs involved. And we published this figure in the MMWR. And the blue line is the one that really caused some concern at the health department. So these are the deaths that were attributed to non-illicit drugs only. And, none of this is news now, but when we published this in 2004, it was exciting. The New York Times called. So we had a medical student work with us in 2005, and he took this picture that's now infamous that is a nice visual demonstration of the increasing impact of a single drug, methadone, on fatalities. So the left-hand stack is the medical examiner case files for the methadone-related deaths in the year 2000, and the right-hand stack is all the methadone deaths in the year 2004. That is a USA Today worthy graphic. So this just really led us to more questions. Did these decedents have prescriptions for the medications that poisoned them? Did we have a patient safety problem? Was it a law enforcement problem for diverted medications? Was it both? And it was at this point that I looked to our state prescription monitoring program, and I thought, hooray, we have data. Like, we can solve this problem. All we had to do was figure out how to link our decedents to our prescription monitoring program data, and then we would know and we could design interventions. No. Let me tell you a little bit. Well, so our state prescription monitoring program is maintained by the Division of Occupational and Professional Licensing, which is in the Department of Commerce. Remember, it's the Department of Health working on this. And it was enacted by legislative mandate in 1995. We have data going back to 1997 for our PMP. And in the health department, we developed a research protocol to link up our medical examiner and death certificate data to our controlled substance data so that we could learn more about the prescription drug-related decedents. Took it over to the database people at Commerce, and they said, that's a great idea, but you can't do it. And I was stunned. But the database had been established with such strict privacy rules that it could only be used by providers querying their own patients and by the database people for investigations. So in the end, it turned out that the most efficient way for us at the health department to access the data was actually to work with the legislature to change the law. And that took about a year and a half. So once I got into the data, I realized that it wasn't actually like golden shining answers that we wanted. The database was never intended for research, and my team was really the first to try and analyze it in aggregate rather than by querying individual patients. We spent a lot of time cleaning the data and discovering things about it, such as how people were entering data with different types of characters. There were 11 different values in the field for patient gender. Okay, this is a problem. There were also a really disturbing number of very young patients who were prescribed anti-anxiety and opioid medications, like 2- and 3-year-olds. And so we investigated further and discovered that there were dogs and cats in the database because this was data coming from pharmacy fills. But our biggest challenge was that the system lacked a unique patient identifier. And so we had to create a combination deterministic probabilistic algorithm to create individual patient histories. And that's gotten better over the years. So fall 2006, We did our first pretty rudimentary linking of controlled substance to medical examiner cases and determined that 47% of our decedents had an active prescription for an opioid medication at the time of death, which meant that if they were taking the medication as prescribed, it would have lasted from the date of fill through the date of death. And we were able to find no evidence of a filled prescription for only 15% of our drug-related decedents from 1999 through their date of death. We then used the toxicology data to see about mixing medications and found that 43% of our identified drug overdose decedents had an active prescription for every drug identified on toxicology at the time of death. And we decided that this was enough evidence that there was a patient safety problem and a problem that belonged to the Department of Health. So I'm going to move now to talking about our legislatively funded research and education campaign. Over the years, we've done a lot of different things, and I'm trying to keep it chronological, but a lot of it overlapped, and it's just clean timeline is impossible. So some of these slides were originally developed by Aaron Johnson. In the 2007 legislative session, we passed House Bill 137, which provided 2 years of funding and a mandate for the health department to engage in research, create prescribing guidelines, and provide education to reduce the harm related to prescription pain medication. So we'd studied fatalities, but one thing that we still wondered was about people who experienced a non-fatal poisoning or overdose and visited the emergency department but didn't die. We have a statewide emergency department database, and in 2007, we linked it to controlled substance data. We saw annual increases in ED encounters related to opioid medications and found that patients with any opioid-related ED visit, the blue broken line on top, used the emergency department more, on average of 3 to 4 times a year, compared to patients with no opioid-related visits, shown in this yellow line, who average 1 to 2 visits per year. In 2008, we began an effort to get more contextual information about fatalities by systematically interviewing next of kin for all drug-related deaths between the end of October 2008 and 9. And during that time, there were 432 deaths investigated by our medical examiner that involved at least one prescription medication. This problem represented 20.7% of all medical examiner cases for the year, and we were able to interview next of kin for 90% of cases. The majority of deaths, 64%, involved an opioid pain drug, and most of these involved only non-illicit drugs. Only 38 of our interviewed cases had combined an illicit drug with a prescription drug. We found that 87.4% of decedents had taken prescription pain medication within 1 year of death, and these medications were mostly acquired from a healthcare provider or from a friend or relative for free. And among those using prescribed medication, more than half were reported by their next of kin to be taking more than prescribed, and many had visited multiple providers in order to get their medications. We were also able to see that more decedents, our overdose decedents, were more likely to be unemployed and without health insurance than the general Utah population. So we also wanted to get more information about people who may be misusing pain medication who hadn't experienced an adverse event. So we added 12 questions to the Behavioral Risk Factor Surveillance System telephone survey in 2008. And among the 5,330 adult respondents, fully 20.8% reported being prescribed an opioid pain reliever in the previous year. 3.2% reported using their own medication more frequently or in higher doses than prescribed, and 72% had leftover medication, 71% of which was kept. So in this telephone survey, 1.8% of respondents reported using prescription opioids not prescribed to them. Now, this seems like a small proportion, but it corresponds to 34,637 Utah adults for that year. Most of those people, 97%, received that medication for a friend or relative for free or as a gift. And so clearly, we had work to do to educate the public about not sharing leftover medication and to educate providers about prescribing medication in amounts less likely to result in leftovers. So we embarked on an education campaign to get the general public more aware of the potential dangers of prescription pain medication and to raise the profile of this problem among the general public. We included public opinion surveys before and after our media campaign so that we could try to measure the impact of the campaign. So we conducted 3 focus groups and a statewide telephone survey and determined that doctors' offices and pharmacies were the primary sources of information about medications for most people, but that most people had not seen information about prescription pain medication in these locations. Opportunity. So we had a lot of things that happened all at the same time. We had TV, we had radio, website, all kinds of collateral materials that we distributed all over the place, print advertisements. There were community events and displays that we attended with our messaging. And we got a lot of coverage in the news media. In kind of the middle there, that 519 is the front page above the fold of the Salt Lake Tribune, where they were talking about the number of cases that the medical examiner investigated that year. It was estimated that our free media coverage equaled more than $200,000 of paid advertising. So we tracked hits to the website during this whole process, and we found that during the TV campaign in particular, our average daily unique users on the website approximately doubled from fewer than 50 to more than 100. And we did follow-up survey research, found that people had noticed and remembered our ads, with 48% recalled the commercial about back pain and taking a long nap from which you might not wake up. And 34% said that the messages made them a great deal more aware of the dangers of prescription pain medication. And 35% had seen information in doctors' offices, 32% in a pharmacy. So we'd raised awareness, but we didn't know if that would translate to behavior change. We also convened a diverse stakeholder group to promulgate prescribing guidelines in 2009, and then conducted education about the guidelines among providers, which brings me back to research. We asked providers in a survey if they had changed their prescribing behaviors because of the guidelines, and then we also used our controlled substance data to examine changes in prescribing behaviors to evaluate the impact of the guidelines. Well, in our survey, which I did in 2011 among primary care family medicine primarily, providers reported that they didn't feel well enough trained to feel confident about prescribing opioids, and that they didn't have referral resources in the community for complicated or addicted patients. They wanted to use addiction screening tools, but really needed them to be incorporated into the electronic medical record because any external tools were just too difficult for their workflow. All right, given the physician's responses, you may wonder if we had any success at all. So I'll show you some data from our controlled substance database that should give you hope. First, our annual number of unique patients captured in the registry came down from a high in 2009, during which 39% of Utah adults received opioid prescriptions. But because of various funding and other challenges, we haven't actually gotten access to updated numbers from the controlled substance database in a couple of years. We're still working on that. But methadone is a drug of particular interest. Remember those stacks of files? The number of patients receiving methadone dropped about a third, from about 9,000 unique patients in 2006 back to levels closer to what we had in 2002. So we think this is actually a good result of one of our guidelines about not going to methadone. This graph displays the number of prescription opioid-related deaths investigated by the medical examiner each year since 2000. And the maximum number here actually occurred in 2007, the year that the legislature began funding prescription pain medication program. And during the time that we had that funding, the number of prescription opioid deaths by year declined 27.6%. And then the year after funding was eliminated, there was an increase, which has continued a little bit. So we take away from that, you can't stop with this messaging. You can't think, oh, we fixed it. And that's a hard message for legislators. I got a grant from the Robert Wood Johnson Foundation to study the impact of another regulation on controlled substance prescribing. House Bill 28, passed in 2010, mandated that prescribers register with our online query system for the controlled substance database in order to renew their prescribing license. So the question is, if providers are forced to register, will we see increased utilization? We can study this using the log file that's associated with the online query system. Once again, we were the first ones to actually try and do that. Not as easy as you might think. But the good news is that system use did increase. More queries are happening. We'd like to think that this means providers are perhaps looking up their patients and deciding whether or not to prescribe opioids based on what they find. But these are data that are a lot harder to come across, okay? So whose fault is this anyway? Physician specialty and adverse drug events. Pain points to primary care, and primary care points to pain specialists. We did use our linked data set to study the problem and discovered that some specialties were associated with more fatalities than we'd expect based on how often they prescribe. But in general, rates of prescribing have come down for all specialties, and that should be seen as a success. Okay, stick with me here. Left-hand vertical axis is the incidence of opioid fatalities per 1,000 opioid prescriptions by physician specialty, and the range on the left is 0 to 35. And all the solid lines are on this axis. We saw a big decline in fatalities in prescribing over the years of data studied. So the right-hand most years, 2009 and 10, are all squashed together. So we have a second right-hand axis, which ranges from 0 to 3.5, and the boxes with broken lines go on this axis. So for each year, the dark square is the annual mean, and the box is the 75th, 50th, and 25th percentiles. Pain medicine physicians are the triangle markers, and family medicine is a circle, internal medicine is the light square, and dentists are the diamonds. So we can see everybody's coming down. Pain medicine was pretty consistently on top. I presented that at the American Academy of Pain Medicine. It was really fun. So many of the aspects of our guidelines are captured only in provider medical records, not in a central database. It's really hard to evaluate implementation. So we did create some indicators for prescriptions within our prescription monitoring program, and I'll show you a couple slides from this, okay? So 5 sets of columns here that represent different patient populations within our controlled substance database. From left to right, acute opioid users, chronic users, intermittent, palliative care, and then everybody together. And then the 3 columns of decreasing color show the time periods. Pre-guidelines on the left, intermediate guidelines period when they'd been disseminated but not yet published, and then the post-guidelines period on the right in the lightest color. And then the vertical axis is proportion of patients whose history includes a guidelines violation. So we saw decreases. This is for our methadone-related flag, and we saw a big decrease here, particularly for intermittent opioid users, where in the pre-guidelines period, 24.2% of intermittent methadone users experienced a potentially dangerous methadone dose, and that proportion dropped to 17%. One of our other indicators was concurrent prescriptions for long-acting opioids, and we saw such prescriptions drop, particularly among chronic opioid patients in our post-guidelines period. And opioid-related emergency department visits among persons prescribed opioids also reduced in our post-guidelines period. These are pretty rare events, but it was still happy to see a sharp decline there. So just a couple lessons learned. We've been studying this problem for quite some time, and it's been really gratifying to watch other states and the nation catch up and then surpass the things that we've been able to do in Utah. And hopefully some of it, what we've done has been a launching pad. Some of the things we've learned, having a unique identifier in the prescription monitoring program is a really great idea so that you don't have to do this whole deterministic, probabilistic linking thing. Ongoing data quality verification saves hassle later when you try to use the data. And in part because if the providers need to know that the data are timely and accurate, or they're not going to be motivated to use the system. And if they're not using the system, then what's the point? We wish that we had physician specialty in our prescribing, our controlled substance database, as well as information about group practices and mid-level providers associated with practices, so we could better, maybe identify some like problem practices. And it would be really cool if we could link our prescription monitoring program with medical records to get diagnoses and other non-controlled substance prescriptions. Maybe all of those statins and opioids are bad together, but if all we're looking at is opioids, then it's going to be really, really tough to know that. And in the future, I would also really love it to see if providers, when they queried someone in the prescription monitoring program, could add data. Like, what if the provider could put in, failed urine drug screen, cocaine, right? And then the next provider that the patient sees the next day maybe can't get the details, but can see that somebody else put in a red flag. That would be pretty cool. And in our current data environment, it might be possible. And I'd also love it if in prescription monitoring program, if a provider queried a patient, and then in order to click out of that patient record, they had to say what they were going to do. Like, I'm going to prescribe, I'm not going to prescribe. Because right now, a patient who's doctor shopping, their story is only going to get better. And they might see 10 providers who don't prescribe, and then the 11th does, not knowing that they've had 10 rehearsals. So I would love to see that. Any of you who are programmers, help me out here. Real time, we have the data. It would be great if we could use it. And I will stop there.
Okay, I have a question that came from the webinar and actually came earlier, but fortunately you touched on these things,
Awesome.
so you get to have the pleasure of answering it. What are your thoughts on making either legislatively or say a hospital policy that physicians check into the PDMP before any prescribing? Whether you think that would be pragmatic and if so, whether you think it'd be an effective thing.
We've heard a lot of people be concerned about legislating or mandating PMP checking. Some states are doing it, and the world hasn't ended. And so I know in our state, there was a lot of resistance to the idea of legislators making medical decisions, because that's what it was perceived as. Hence, we only could say that they had to register. We couldn't say that they had to use the system. But I think now that, we see the experience that they've had in Kentucky, and it's still going okay, and people are still getting medical care, I suspect that we're going to see a lot more move towards mandatory checking. Yes, I do think it'll help. I really do think it will help, because we see in our data, I presented about dual prescription of long-acting opioids. We have separate indicators for if it's actually from the same physician or from different physicians. And one would probably be shocked at how often a single patient had concurrent prescriptions for 2 long-acting opioids from the same provider, right? And, I don't know how that happens. And we required some pretty, at least 7 days overlap, and we gave him a little bit of credit for the fact of if the data couldn't have been in the PMP yet and stuff like that. But I think if we force people to check, there's a lot more opportunity to catch things that are patient safety challenges. And, patients may be seeing multiple providers for legitimate reasons who aren't talking to each other. And, the little old ladies who are going to keep taking the medication that the first doctor gave them, not realizing that it's really the same as what the new doctor's giving them, and wind up in trouble.
I always have to say something about the mandatory prescription drug monitoring checking.
Please. I'm not that kind of doctor.
And I guess it's just that with anything that takes time, there is a trade-off. And so, and there are very many different settings in which opioids are prescribed. And so for something that may be extremely high yield in an emergency department setting, for example, could be a lot lower yield in a setting where someone has a limited panel of patients that they give 12 prescriptions per year to. So, those 12 checks on the same person, the highest yield will be with the first check, or maybe one every once in a while. So just always adding that little.
Well, and but I agree with you that there are many different settings, and in some places, access to PMP is easier. In some places, it's impossible, as I've learned from my friend from California. But some places it winds up integrated into the EMR, and I think where it's feasible, I would like to hope that all of these physicians would prefer to have more information about their patients. And maybe as time goes forward and we can make it easier in California and have a prescription monitoring program actually exist in Nebraska instead of just something on paper, it might help.
So one thing I was just going to say too, in terms of your death certificate data, I really appreciate that you've been thinking very carefully about what death certificates can and cannot tell you. I always, as someone who has filled out death certificates, indeed filled out death certificates for people I've never met and have no idea why they actually died. This is how many death certificates are completed. And so they always need to be taken with a grain of salt. I just wonder, thoughts about other sources of data or information about medical events that could be attributable to opioids that are, for example, in older people? Or how have you thought about new directions in terms of trying to find and define those events?
So one of the things I've thought a lot about is actually respiratory infections, where, in winter, it is not unusual for people to die from pneumonia, influenza. But I wonder, for how many of those people was it their completely stable Lortab for their back pain that compromised them just that much so that they got pneumonia and died? And I don't know. This is one of the things that we're starting to think of. We looked a lot more closely at our suicides in the past few years and found some fascinating things, particularly in the older adult population, that the men who were committing suicide with medications, it wasn't their medicine. It was much more likely to be medication prescribed for their spouse. And so we're looking into some of those directions about actually thinking about risk stratification at a household level instead of just at a patient level.
I have, I think I get 5 minutes later today to talk, so I'm going to eke out one more minute here. I noticed in your trend data for deaths due to various substances and multiple substances, you didn't include alcohol. And there's no question that alcohol interacts with benzos pretty powerfully, as well as with opiates and opioids. And have you looked at alcohol? Did you just not include it, and what have you seen if you did?
Why, yes, I have.
Okay.
So in all of our review of the medical examiner data, at least in our Utah data, alcohol is involved in approximately 20% of all substance-related deaths, and it is consistent between illicits, non-illicits. It's there. The thing is that it just hasn't been as focused for us. In our population, in Utah, alcohol is perceived as a pretty small problem, and we haven't seen changes over the years in people who are taking medications with beer and other things. So we do not mean to neglect alcohol. It just hasn't been our focus.
Presentation. I want to back up to one thing you said early on, which is originally the law in Utah did not allow you to look at the data, which is the position we're currently in Michigan. And first of all, to commend you that in a year and a half, you managed to change that. Take 2 bows for that, because that's a very short amount of time. And then also just to put out there once again what amazing things you can do once you do shift that policy to get the agencies to be able to cooperate and work together to be able to then have the data to make the changes in the public health.
Mm-hmm.